first and the most important thing that you have to do is, if initially when you're reading the case, is don't put your mind into anything except understand what is a chief complaint. If your chief complaint says that this patient has he presented with, like for example, um, dizziness, just focus that what are some of the most important differential diagnoses for dizziness. Of course, you're going to take age into consideration, but at least come up with a quick understanding, because your mind at that time is very anxious. So when you hear dizziness, the most important thing you should do is come up with the differential diagnosis. That's your read number one, which is going to be a very fast read. It's more than like less than 10 seconds. You just say 35-year-old patient presents with complaints of dizziness. Please take history and address concerns. You didn't even pay attention to anything else except for dizziness. So the minute you see that, you're going to start to have that 2 minutes time. In that 2 minutes time, the first thing you do is you build your differential diagnosis. If your differential diagnosis is weak, when you go inside the room, surely you will ask all the history questions, but it will just make you feel like you have no important questions to ask when it gets to your differential diagnosis. So therefore, rather than writing the age or the name and all that thing, it's not as important for you. The differential diagnosis is very, very important, because if you forget the age or the name, you can go back inside the room and put that chart up and say, hey, you know what? Mr. Johnson, can you please give me 1 second? I would like to read your chart one more time. I want to make sure everything is, I've understood everything correct. You can go and cheat the name again. Look at the name and you can come up with the age and name if you're missing that out, right? Or you can just ask the patient, hey, please confirm your name and your age. If you just don't know how to like, tell them that what's your name. But if you know the name, it's, of course, it's a really good thing. By walking inside the room, you can just say, hello, Mr. Johnson. Is this Mr. Johnson? And he's going to be like, yes, I'm Mr. Johnson. All right, great, Mr. Johnson. Can you please confirm your age as well? They will be like, I'm 67 years old. Okay, thank you so much for the confirmation. I'm Dr. Then you introduce yourself. So you introduce yourself. But I just wanted to tell you on how much important it is, the name and age compared to your differential diagnosis. So don't worry about name and age right away. First thing and most important thing, write the most important differential diagnosis. That should be clue number one to you guys. I mean, start of your case, outside the door. We're outside, we're not even inside yet. After that, once you plan that, then you can go ahead second time. You read over the case. When the second time you read over the case, this time you understand the name of the patient. You can possibly pick up the age as well, and your task, what you're doing. Of course, either you're doing a physical, because I know a lot of students that I had mock with literally came inside and they didn't know they had to consult. They didn't really know they had to do a physical, just because they were not aware of what they were doing. And that's a very embarrassing moment when you're in a room like that and the examiner looks at a very weak point. Instead of someone telling you, oh, you have to do a physical, or they might not even tell you, they just walk away like, okay, are you done? Sure, let's leave. That's all. So make sure you know what important task you have to do. That's another important task. Another important step number two. Step number one was differential diagnosis. Step number two was what task are you doing? And then step number three is basically, I'll just put that for you here. Step number three would be the, for example, name, which is very fast to write age. And if you have possibly time, then you can just write some workup that you will need for workup for post-encounter scenarios. Like let's say you, for example, you have already a dizziness case, and you know the dizziness could either be vertical or it could be some sort of hypotension. So my workup should be based on ECG, orthostatic blood pressures, get a echocardiogram to make sure there's no aortic stenosis, get like basically, as well as check his medications, and that's it, physical examination. So this is a big, broad, vast, like kind of workup you want to do. Of course, when you get inside the case and you get more understanding of what is this could be, what if this could be vertigo, if this could be anything else, then you do a Dix hap-like maneuver, or many other maneuvers to make sure you can come up with the diagnosis. But just for the time being, just write a quick, a huge picture of, hey, I have to do an ECG, I have to do an echo, and I have to do basically a physical exam and orthostatic examination. If you don't even later on have any idea, this will help you so much. So this is why this is like a bigger picture. I'm not trying to tell you guys that you're gonna get your main workup right away in the beginning. No, but at least it gives you an idea that this isn't what I'm about to do after when I'm done, when I'm about to answer my post-encounter question. So I need to keep that in mind. But that's only if you have enough time in the 2 minutes period. Don't worry about it if you don't have time. You still have the whole 8 minutes when you're doing history. You will eventually find your work up slowly, slowly. Again, we'll focus on the 2 minutes outside the door. So first, number one, and the most important things, always write your differential diagnosis before you walk in. At least minimum of four. The more, the better, but four is perfect for you. And especially if you know the settings. Once you know the setting, if this patient's in an office or the patient's in an emergency room, then you can base your differential diagnosis according to the age or setting, which is a little bit better, of course. This is why in the beginning, when you read, you already know it's 47-year-old female. So it's not anymore like a big deal for you to memorize that thing. So when you get to your differential diagnosis, just try to remember the most common differentials for that lady, for the ladies in the emergency room. Of course, if it's pelvic pain, it's all PID, STDs, pelvic inflammatory disease, STDs, ectopic pregnancies, ovarian torsions, appendicitis. I can give you many and many because the most common for women, right? If it was a man, sigmoid colitis, colon cancer, a rupture of appendix, rupture of gallbladder, and testicular torsion. That's it. So as long as I know it's male or female, which setting are they in, I should be able to right away come up with four differentials without any hesitations, okay? And that's what's going to make your whole case later on. As we talk about, I'll mention again to you guys that how important the differential diagnosis is. Other than that, there's no need for you to write this mnemonic of, oh, I have to write PQRST and then I got a check mark in this things and then carry this paper on you. Nobody's going to ask you for no papers. Nobody's going to ask you, oh, can I have the paper? And before in the US exams, they usually used to say, okay, you know what? You have a paper, you can write in the paper, and in the end, you have to return the paper to the examiner. That was the CS exams. Even that, they didn't check it much. But when I was giving the exam, I didn't know that how important was writing on that paper. It was literally taking away from my time. It was taking away from my way that I was having a eye-to-eye contact with the patient. And just because I was not prepared, I didn't have a template. So I was literally going on a mnemonic to mnemonic basis. But rather, I could have just memorized my one template and then incorporate every single case into that and ask the same way. How hard it is for you to follow step by step like pattern. Even if you didn't get your differential, I'm telling you, your diagnosis, you will still get a really good mark in your history because that it has been shown that people who do good history does not always have to get the diagnosis, and you don't have the diagnosis until the post encounter. So the post encounter is only about 20% of your mark, 20-25%. So you're messing up with 75% compared to 25. Okay, so I hope you guys have no questions. If you guys have any questions, please unmute your mic sometimes because I don't look at, as I said, I don't look at that message box a lot. And ask me the question before I move further, okay? All right. So this was the outside of the door kind of scenario. Now we're very calm and we're like about to walk into the door, and the time says, well, examinees, you can walk into the door now. Um, you knock into the door, walk inside the room, and first of all, of course, you have to have a really nice gesture of like smiling gesture to the patient as well. Then you go to the examiner or to the examiner, and then you say, hello, my candidate code is 123456. Can I proceed, please? Sure, go ahead, doctor. All right, then you turn around back to the patient. You come back to the patient. Even though in the beginning you didn't say hi or hello to the patient, you just smiled, hello. That's all you did. And you walk towards examiner because you have to first present yourself to him by giving your candidate code and everything like that. And for sure, if you want to sanitize your hand, that's up to you. But most likely, we're not having any patients or anybody to touch, or we're not shaking hands. So hence, no need to sanitize it right away. You can just say your candidate code and walk away. Once you walk away, you come back to the patient. Now we're actually going to be dealing the whole time with the patient. So you walk in, and let's say you walk in near to the patient, you're going to stay away a little bit, like about 6 feet away from the patient due to the COVID, of course, and just be very calm and mention. If you, as I said, if you know the name, it's very good. Mention it. If you were in a rush and outside the door, you guys couldn't actually, like, you didn't have enough time to memorize the name or the age, don't be lost. Don't be so, don't lose your confidence. Just say, hello, can you please confirm your name and age for me, please? Well, my name is Jacqueline Fernandez, and I'm 47 years old. Thank you so much, Miss Fernandez. You see how I noticed it? She's 47, so anybody greater than 18 years old, we call it Mr. or Mrs. And anyone less than 18 years old, we call it by the first name. That's all. So the introduction part, I'll write here. If it's less than 18, first name. Greater than 18, Mr., Mrs., or Miss. So one of these things is perfectly. You can say, okay, hello, Mrs. Fernandez, because of course that's the last name she has. So she's going to become Mrs. Fernandez, right? If she says, and then once you say hello, Miss Fernandez, as Miss Fernandez, is it okay if can I address you as Miss Fernandez, or would you like me to address you differently? That's it. So initially I walked in. If I don't know the name, I say, what's your name and age? Once you confirm, you can say, okay, can I address you as Miss Fernandez? Sure, doctor, no problem. If you initially started with the name and say, hello, is this Mrs. Jacqueline Fernandez or Mrs. Fernandez? Yes, doctor, this is Miss Fernandez. How old are you, Miss Fernandez? I'm 47-year-old. Great. Honestly, a lot of the time people really don't have to confirm the age, but just for a good professionalism, you have to confirm the age. It's really good. But the minute that you say the name and they confirmed it, it's perfectly fine. Uh, then after that, finally, when you said that, okay, so nice to meet you, Ms. Fernandez. I'm doctor. Then you introduce yourself. Once you confirmed, you introduce yourself. I'm Dr. Kadri. I'm the physician on duty today, and I was asked to look after you. Is that okay with you? Yes, doctor. Absolutely. That's okay with me. Great. Ms. Fernandez, is it okay if I have a seat? If you see that the patient's sitting down on a table, of course, you have a seat right in front of you. Don't hesitate to sit down. There's no need for you to stand up. Unless the patient is like yelling and crying or holding onto the pain and you're in an emergency room, then of course it's not worth it to just sit down. It's better to stand up close to the patient and try to ask your question in a professional way and just like finish it as soon as possible. But if the patient's very calm and she's answering well enough, just relax yourself. Say, is it okay if I have a seat? Because you are going to be tired standing up for the whole time as well. And not that, of course, during the exam it doesn't feel like you will get tired, but it just you don't have the same confidence when you're sitting down and you're very calm. Like, you can ask different questions. You can kind of like basically go deep into the history. That's what I'm trying to say. Sure. No problem, doctor. Please have a seat. Uh, so here we go. Let's go ahead back and kind of give you guys a little clue. So I said, hello, is this Miss Marina? This is the lady, right? Yes, doctor. She says yes. So then I'm going to start with saying, I'm Dr. Kathy, the physician on duty today, and I have been asked to look after you. Is that okay? Sure, no problem. That's what she's going to say, of course. And then you go ahead, you say, can I have a seat? Thank you. Well, of course, you have to say, thank you very much. Thank you very much, Miss Marina. Appreciate that. This is how you communicate. When they say something, always try to be back at them. Don't leave them hanging. I know I had a lot of some of the students, and I've noticed that when I was talking to them, I would say, oh, thank you so much, doctor. They'll be like, okay, so next, not like that. You should say, you're welcome, Mrs. Marina. So let's move on. This shows much more better communication than saying, so what's your name after this? Like, just saying, oh, what's your name? I say thank you. You reply to me, you're welcome. That's all. It's a quick word. You don't have to much worry about it. It's not going to waste your time. All right. So after we say, is that okay with you? She's going to say, yes, it's okay. So you say, can I have a seat? Then you sit down. This is where you're going to start your actual professional introduction now. The first introduction was with the greeting. We call it the greeting. So you greeted the patient. Next step is the professional way of building doctor-patient relationship with this patient. It's called the actual introduction, and this is going to be a very important one. And so make sure you guys know. So of course, when you sit down, the first thing you do before I even put that up, I will make sure that I explain what I'm about to do. I'm going to explain in like 30 seconds what I'm about to do, or even 20 seconds what I'm about. Depends on how many times you repeat this, that's how fast you're going to get. Of course, if I ask you to do it right now, it can even take you up to 40 seconds, 45 seconds to introduce yourself properly. But the more you have repeatedly read over this and introduced yourself in every case, it becomes like a piece of cake. So you guys will be very happy to have this kind of introduction in your case presentation. And on top of that, the examiner will love to hear this kind of things from you, because that shows that your attitude, your the way of professionalism, your communication, and everything is just in one introduction. I can present all that. So next, what you do, so you tell them about what you're about to do. Of course, you're about to tell them that I'm here to, for example, if it's history, I'm here to do a history examination, take some, ask you some question about the medical condition of